morning, everyone. Welcome, and I thank you for joining this learning series webinar, The Rise of Polysubstance Overdose Deaths in New Jersey. And it's such an important topic here in New Jersey and everywhere else. So around the country, I know we're seeing more and more of this, so I appreciate everyone joining us. Today's webinar is designated for one AMA PRA Category 1 credit, one ANCC contact hour, one ACPE contact hour, one AAPA Category 1 CME credit, and one ADA CERP continuing education credit. For any pharmacists claiming credit, please note that your credit will be uploaded to CPE Monitor within 30 days. While we have no disclosures for faculty of this learning event, PA Planner Dean Barone discloses that he serves on the Speakers Bureau of Ethicon, and all other planners have nothing to disclose. So that's our housekeeping for today. Today's webinar is jointly provided by the Partnership for a Drug for New Jersey and the American Academy of CME Inc. and is being held in collaboration with NJ Cares, the New Jersey Office of the Attorney General, and the Opiate Education Foundation of America. And I thank them for their partnership, support, and collaboration on today's learning activity and throughout this year-long series. I am so pleased to welcome today's expert panels. We have Dr. Andrew Falzone, our Chief State Medical Examiner for the state of New Jersey, and Dr. Rachel Haraz, the Associate Professor, Department of Emergency Medicine at Cooper Medical School at Rowan University, and the Division Head of Toxicology and Addiction Medicine and Medical Director for the Center for Healing. Unfortunately, Dr. Michael McCormick from the ONDCP is unable to join us today, and he gives us his regards, but we are looking forward to having him join us at an upcoming event. And so I will turn the presentation over to Dr. Falzone. As I mentioned, we know this is a really important and trending topic. And so Dr. Falzone, we'll start with you.
Okay. Thank you, Angela, and good morning, everyone. So it started out as a prescription abuse-driven opioid crisis back in 2010, has evolved over the years into a complex and multifaceted problem that has affected individuals from all walks of life. Novel drugs have been introduced, and drugs such as, the fentanyl analogs and the novel psychoactive drugs have been introduced into the illicit market. And drugs that had been once popular in the past have made somewhat of a comeback. One of those re-emerging drugs is methamphetamine. In this short presentation, we will go over the what, where, who, and why of methamphetamine use, particularly in the context of the opioid crisis, which really has had a huge impact on drug deaths in general. Next slide. For starters, what is methamphetamine? Methamphetamine is a synthetic drug, so it's not a plant-based drug. It can be produced from commonly found chemicals, and that's why when you go for your ephedrine prescription, not prescription, when you have to present the driver's license, because that can be used as a basis to produce methamphetamine. So the drug was first synthesized back in 1893 and has been used clinically since 1930. Methamphetamine is a potent CNS stimulant that is mainly used as a recreational drug. Methamphetamine is also a Schedule II drug, meaning that it has a high risk for dependency and addiction, but it can be used in limited conditions, and it can be used as a second-line treatment for ADHD and obesity. Given its stimulant effects on the body, the drug was widely used during World War II by both sides, and this had actually caused some soldiers to commit violent crimes against civilians and even attack some of their own officers. Next slide. Um, Methamphetamine has numerous psychological and physiological effects that are affected by numerous factors such as the dose, dosing frequency, the form of the drug, the route of administration, and the chronicity. By stimulating mediators, serotonin, dopamine, and norepinephrine, and blocking the reuptake at the synapse in these cases, the drug enhances pleasure, mood, and it modulates appetite. Probably the most significant psychological effect of methamphetamine, which is the cause for it being such an addictive drug, is the rapid, intense rush or euphoria, which one gets, particularly after either smoking or injecting the drug. After this intense rush, one becomes extremely alert, active, energetic, and restless with enhanced sexual desire and arousal. And these can last anywhere from 6 to 24 hours. The drug suppresses appetite. So in the beginning, it can, have kind of like somewhat of a positive effect because it leads to weight loss. But as chronicity ensues, they start to develop malnourishment due to an extremely poor diet. It does produce anxiety and paranoia, and any pre-existing psychopathology, any pre-existing psychiatric conditions will be exacerbated by the use of methamphetamine. It can also produce homicidal and suicidal ideations, which is why performing toxicology is so critical when we have case of suicide. The drug produces a tactile hallucination. It gives the user the sensation of having bugs crawling under the skin, which results in excessive itching and scratching, which then leads to the classic sores that we see on the skin of methamphetamine users. Next slide. Methamphetamine, like I said, also produces physiological effects, and these are going to be responsible for the overdose deaths that are related with the drug. Being a stimulant, obviously, it's going to produce a dramatic increase in the heart rate and blood pressure, and any underlying cardiac or vascular pre-existing conditions are going to be impacted by the sudden surge in heart rate and blood pressure. So things like strokes, ruptured aneurysms are commonly seen in conjunction with stimulant drugs, and methamphetamine, is a classic case, a drug that produces these findings in deaths. It also produces irregular heartbeats or cardiac arrhythmias. And again, any pre-existing conditions, whether it's genetic or acquired, can lead to the toxic effects of the drug end up causing the death of the person. The vasoconstriction, the narrowing of the blood vessels in various parts of the body can have an impact on that particular region. And this obviously includes the brain and the kidneys. Chronic use of drug causes pericarditis and inflammation of the lining of the heart. And it can produce other effects such as headaches, decreased appetite, tremors, chest pain, again, due to the vascular effects on the heart, and increased respiration, Hyperthermia is a classical finding, especially in situations where you have an excited delirium type situation. And that's why it's extremely important that, medical legal death investigators that are working up the scene, if they have access to the body, shortly after death, it's important that a body temperature be recorded, because that's a classic finding in such cases. Obviously, any of these signs and symptoms will be more pronounced when the drug is taken in conjunction with other drugs, including alcohol, cocaine, heroin, or cannabis. Next slide. These are classic photos that there's tons of them online, which show the rapid aging appearance in chronic methamphetamine users. Skin picking from the tactile hallucination leads to scratching and sore formation. Any pre-existing acne will be exacerbated. The decreased food intake combined with the increased metabolism that comes from the stimulant effects of the drug causes loss of muscle and fat tissues, giving a hollowed out appearance. Another classic sign of chronic methamphetamine use is what is referred to as meth mouth. And this is due to multiple factors, including the fact that people who use meth tend to grind and clench their teeth while they're experiencing a high. The drug also produces decreased secretion of saliva, which gives a dry mouth. The users also crave sugary drinks. And obviously, when all this is going on, the people tend to neglect hygiene in general, including oral hygiene. And this all leads to the teeth having a shrinkage appearance. Next slide. This is a graph, and we see a lot of these online. This here illustrates the death rates that are associated with various drugs for the time period between 2013 and 2019. The solid line somewhere in the middle there, that reflects the cases associated with prescription opioids. And you can see there was a slow increase in the number of drug-related deaths, peaking at around 2016, followed by a slight decline in the number of deaths associated with prescription opioids. Underneath it is the line for heroin-related deaths. You can see as the abuse of prescription opioids progressed, so did the number of heroin deaths, again, peaking around 2016. And we've even seen a decline in the number of heroin-related deaths that somewhat mirrors that of prescription opioids. Psychostimulants and cocaine have showed somewhat of a steady increase, but the most dramatic finding here is the number of deaths that are associated with fentanyl use, and that has been the major driving force in the drug-related death crisis. What this graph fails to capture is the prevalence of multi-drug toxicity, where you have more than one drug present in the system that is causing a fatal outcome. More often than not, one of those multiple drugs is going to be fentanyl. The vast majority of cases of drug-related deaths that we see today all are going to have 2 or 3 drugs. And again, one of those is going to be fentanyl. Next slide. Another way to display data is to document the increase in the occurrence of the drug. It's a well-known fact that the methamphetamine is predominantly a West Coast problem. This kind of like map here actually shows that the increases is more dominant in the eastern part of the country. And unfortunately, New Jersey is actually listed as having an increase of 733% of methamphetamine-related deaths, which is actually the highest increase in the entire nation. So this obviously prompted us to take a deeper dive into our database in order to find out what was actually going on. Next slide. When we looked through our database and we plotted the number of methamphetamine deaths, we saw that there were actually no methamphetamine-related deaths in 2015 or 2016. After 2016, there was a sharp increase in the number of deaths, which prompts us to ask, so what happened in 2016? As our DMI partners could more likely attest, that there was actually an increase in the seizure and the availability of methamphetamine in the state, which led to a real increase in the number of methamphetamine-related deaths. Something else that happened in 2015, I got hired, and one of the things I did was I took a look at the way drug-related deaths were being reported and classified, and many drug-related deaths were were being classified as being due to adverse reaction to drugs or drug toxicity. So they were not capturing the specific drugs that was leading to the person's death. So we changed the format from there onwards. So now whenever somebody dies of a drug-related death, we say toxic effects of, and we list all the drugs that are being listed. Next slide. Again, this is a map from 2003 showing meth users in rehab, and you can see how it's predominantly on the West Coast. It becomes less prominent as you go south, and even less dominant as you move from the West Coast to the East Coast. Next slide. Looking at meth-related national statistics for 2015, 2019, one sees an increase in overall methamphetamine-related deaths with a 170% increase, and also an increase in the number of arrests for meth possession and meth use. When you compare 2017 to 2020, we see kind of relatively a more modest, not the 733% increase, but we see a 212% increase in the number of deaths. Next slide. When you look at methamphetamine by county in New Jersey, you can actually see that it's somewhat of a regional problem, and we see more of the methamphetamine-related deaths in the southern part of the state. Next slide. When we look at the southern counties, you can actually see mixed success with regards to combating the issue. Atlantic, Gloucester, and Cumberland County show a decline in the number of drug-related deaths, while all the other southern counties actually show an increase. Next slide. When we look at the methamphetamine-related deaths broken down by race, like we see in the overall drug-related deaths, they're going to be predominantly white. And we see 13% in the Black population and 8% in the Hispanic. Obviously, these percentages will change when you look at the actual rate, taking into consideration the population size of each group. When you compare males to females, drug-related deaths, typically we see a 3:1 ratio. We see slightly more females here with a 70-30% distribution. And then when you look at the age, we see that the peak for methamphetamine-related deaths is in the 31 to 40 age group, whereas in the general population, we tend to, when in the general overall drug-related deaths, the peak tends to be more in the 41 to 50, 51 to 60 age groups. So with methamphetamine users, we see somewhat of a younger population using methamphetamine. Next slide, please. Looking at deaths by race, and these are going to be these are rates more than rather than actual, raw numbers. So when we look at fatalities for white individuals, overall, the southern part of the state has the predominance of the number of cases. For the Black population, they're more concentrated in Salem County, whereas for Hispanic populations going to be surprisingly in Warren County. So these are counties that have a little more rural than, say, North and Central Jersey, and probably less access to healthcare facilities. Next slide. So like I said, most drug-related deaths that we see tend to have combinations of drugs. When we look at methamphetamine, only about 12% have exclusively methamphetamine. Again, as I alluded earlier, the predominant drug is going to be fentanyl in conjunction with methamphetamine, with 8% of the cases having methamphetamine present. Obviously, these numbers don't add up to 100, and that means that in most of these cases, you may actually have 2 or even 3 drugs present. Next slide, please. So one asks, what are the motivation for the co-use of methamphetamine and opioids? For starters, meth abusers often are previously addicted to other drugs, namely opioids, and these may be added on to for its enhanced effect. The combination is taken because a lot of times it produces a greater than synergistic effect versus when either drug is taken alone. Sometimes they are taken so that one drug reduces the unwanted side effects of the other drug. So it reduces the agitation from methamphetamine, or the methamphetamine improves the sedating effects from the opioid. Sometimes the combination may produce unique subjective desires. Obviously, it's going to be dependent on the availability. If you don't have it in the local market, you're not going to get it. And financial, because these drugs are synthetic and easy to produce locally. They tend to be cheaper than other drugs, so that could also be a factor in the choice of using methamphetamine. There are also misconceptions regarding the drug, and people tend to think that taking methamphetamine makes taking heroin safer. And I think in many cases, a lot of these cases are going to be taken unknowingly, using tainted drugs that may contain mixtures of drugs that one is not aware of. Next slide. So to wrap things up, some key takebacks. Like the nation, New Jersey has experienced a real increase in the number of drug-related deaths that are due to methamphetamine. The death rate from methamphetamine is more often due to polysubstance use. And unfortunately, research has shown that people who use both substances tend to have poorer outcomes, including high-risk behavior and overdoses. Methamphetamine usage poses novel challenges for the prevention, treatment, and harm reduction. As we saw, many of these cases take place in somewhat more rural areas with limited access to healthcare. And even though the drug has been around for more than 70 years, the treatment approaches for the management of methamphetamine use are still in the early stages of development. As we saw, methamphetamine use, even within the state, is somewhat of a regional problem. So as meth use and harm escalates, the need for improved surveillance, prevention, and treatment options becomes particularly critical, highlighting the need for research in epidemiology, intervention, and treatment. That's all I had. As Angela said, we'll be happy to take your questions at the end of the next presentation. Thank you.
Thank you, Dr. Falzone. Thanks for that. Really important information. And, as we look at polysubstance use and overdose, it's important to understand what we are seeing out there. So thank you. As you mentioned, we'll be taking questions after our next speaker, Dr. Harroz. Just before Dr. Harroz, I turn it over to you. I just want to make note that information on how to obtain credit will be provided at the end of the presentations. So I know there's been a lot of questions on that in the chat. So I just wanted to mention, but Dr. Harroz, I am going to turn the presentation now over to you.
Thank you so much. Can you guys hear me? Yes. Okay, good. So Dr. Falzone, thank you so much for that. I will say as a provider, as an emergency medicine physician and addiction medicine physician in the southern part of the state, I can clinically corroborate what is happening with methamphetamine. We certainly were largely spared methamphetamine for many years compared to what was happening out on the West Coast and the Midwest. But in the last few years, we've seen a surge. And interestingly, many of our patients that do have methamphetamine in the urine are unaware and are not using it intentionally. In fact, I many times have to turn the screen and show them because they don't believe me that there is in fact methamphetamine, and they really, having a very unpredictable drug supply, definitely complicates this. So, but today I'm going to talk a little bit about a different substance, and I think a substance that many of you have heard of. Certainly, it's been on the media. It's been coming out of the White House. And there's been a lot of focus on this particular substance, this adulterant that we have been finding in increasing amounts. Next slide. So as many of you know, about a month ago, the Biden-Harris administration basically designated xylazine, really xylazine, when in the combination with fentanyl, as an emerging threat. And they did that for two reasons. One, because the increase in forensic lab positive testing across the country had increased dramatically in a very short period of time. And there had been, in some areas, over 1,000% increase in xylazine, in the presence of xylazine in overdose deaths. And so with that quick advent, that qualified for an emerging threat, that was announced back in April. Next slide. So what is xylazine? Some of you may have heard it. Some of you may actually know it as tranq. It actually was created by Bayer Pharmaceuticals back in the 60s. And initially it was, when it was first designed, it was designed as an antihypertensive agent. However, when they did utilize it on humans, what they found is that they had to stop the trials because there was significant amount of hypotension, sedation, and it was decided that this was actually not safe in human use. And so on the other side of that, it was actually approved as a veterinary medicine, and it is actually a very popular and widely utilized veterinary medicine for sedation, muscle relaxation, and approved for many different animals. Now, on the street, it is often known as anesthesia de caballo, and in Spanish, because actually the emergence of xylazine as a contaminant, adulterant in at the time heroin supply was actually in Puerto Rico. And we actually saw that data from about 20 years, emerged about 20 years ago. That was some of our first information. And now, as I'll show you in a little bit, it really has moved across this country. The focus still being the Philadelphia, South Jersey region. Now, it is often referred to as trank or trank dope. It has several different name brands in veterinary medicine. This is just one of them. It comes in different vials with different concentrations. And in the veterinary space, it is often used with ketamines or barbiturates. Next slide. Now, what does this medication look like pharmacologically? So it's an alpha adrenergic agonist. So it's a central alpha-2 agonist. And what does that mean? It means that it actually will decrease norepinephrine. It decreases acetylcholine. And interestingly, it actually acts at a couple different receptors. So it actually has histaminergic, so it acts at the histamine, dopaminergic, and it even has some activity at the mu receptor. If you look right here on the slide in the bottom, you'll see clonidine. And if you look, you can see the similarity in the actual structure. The similarity is not just structural, it is also pharmacological. Now, in terms of effect on human mortality, the lethal dose isn't quite known. And you can see here that it's quite a large variant between 40 and 2,400. And the reason for that is that we have probably somewhere between 40 and 60 reports of effects on human intake. So some of them were intentional overdoses, some of them were accidental overdoses. And in the cases that were actually lethal, the doses varied quite a bit, also because many of these individuals were able to be resuscitated. And so that's why you'll see that large variation. I will point out there is a wonderful article that just came out recently, just a few months ago, by Sherry Kasinko out of NMS and some of her colleagues. And it's a really great pharmacology review and prevalence. They do a lot of testing across the country, and they've been routinely testing for the xylazine. Next slide. So you can see here a little bit of the prevalence. The top left is actually a picture taken from the Kasinko article. And you can see it's actually A is 2019, B is 2020, and then C is 2021. And it shows you the increased prevalence of xylazine in samples being tested. Now on the right, what you see is in kind of a color format, the increases based on percentages across the country of xylazine. So in red is the highest percentage, and you can see that is concentrated in the Philadelphia, South Jersey, Baltimore region, where really we saw it the earliest after Puerto Rico, and we've been seeing the highest percentage of prevalence. Next slide. Another thing that is interesting is just the growth by region. So you can see here that the South and the West have had the highest increase in identification of xylazine in the samples from 20 to 21. And then in terms of overdose deaths, which is what I pointed out earlier, the South actually had over 1,000% increase in xylazine presence in overdose deaths. Next slide. This data is very specific to New Jersey. And you can see here, this really just shows how much xylazine is being recovered from some of the drug seizures. This is from the DMI. You can see that in 2021, we had quite a bit, 240,000. That dropped in 2022. But if you look at 2023, in our first quarter, we've had almost 60,000. So we're on target to increase that as well. Now, on the right side, you'll just see it by county. You can see just for the overall, Camden has the highest submissions. And then over on the right, you can see it's a little bit more spread out between Passaic, Atlantic, and Camden. Next slide. Now we do look at a lot of our data from Philadelphia, and that's because, and I'm in Camden, I'm a little bit biased. We do share a drug environment with Philadelphia. Many of our patients do go back and forth. It's actually a very quick train ride. And so in Philadelphia, they have up to between 70 and 90% of their opioid drug supply in the city has xylazine in it. And so they have been tracking this the last 2 years. And what they've seen is they've just seen in the last year from 2019 to 2021, they saw a significant increase in the presence of xylazine in the overdose deaths. Next slide. Now, I put this on there because I think this is very interesting. So the biggest concern has been xylazine is a sedative, opioids are sedatives, fentanyl is a sedative, is a depressant, and the combination of those is thought to be synergistic. And so what you see on the streets is that, patients are unresponsive, not breathing, they receive Narcan, naloxone, and there is only partial reversal of the overdose. And that is thought partially to be xylazine because it has another component of sedation to it. This is an interesting study because it's actually by Jen Love, and they looked at multiple emergency departments, and they looked at overdoses, opioid overdoses that were coming in across the country. And they looked at the presence of xylazine, and they looked to see how the xylazine contributed to actual outcomes. They looked at 321 patients, of which about 83% received Narcan, naloxone. And what they found is those patients that actually did not have xylazine were more likely to have a cardiac arrest or have a coma and have a poor outcome. And more patients that were discharged from the emergency to actually were xylazine positive. Now, why that is happening, there's a couple different theories. The theories are, well, maybe if the patients are using xylazine, and I'll talk about that in a second, because the onset of xylazine is actually sooner, it's quicker onset, it lasts shorter, and patients report that they basically pass out, they go out. And so possibly the patients using the xylazine are using less of the fentanyl, and maybe the samples actually, if they have more xylazine, then they actually contain less fentanyl. The truth is we don't know, but we do have the study that points out that xylazine, even though it's contributing to overdose, may actually in some strange way be protective from cardiac arrest and death. Next slide. All right, now what about xylazine withdrawal? Now, what do we know about that? We know that xylazine is very similar to clonidine. And we do know that clonidine does have a significant withdrawal when it is abruptly stopped. A lot of patients who take xylazine anecdotally will report withdrawal symptoms that are similar to opioid, but do come on sooner and do have some variation. Now, this picture actually is actually one of our patients, and this was a case report that we published last year of a patient that came in, and I'm going to talk about the wounds in a little bit, but this patient came in with wounds, and she was very worried about getting her wounds taken care of because she was worried about the xylazine withdrawal. And we saw her in clinic, and then we sent her right to the emergency department where she was admitted. And next slide. And then over a period of many days, treated for her xylazine withdrawal, opioid withdrawal, as well as xylazine withdrawal. What was interesting about her is that a lot of her presentation was agitation and autonomic dysregulation. So her pressure was up, her heart rate was up, she was very agitated, she was diaphoretic. And you can see here, and you'll see just over the next few slides, all the different medications that we gave her in order to have her comfortable. And what's a little bit different is we gave her something called dexmedetomidine, which is very similar to xylazine and clonidine. It is also an alpha-2 agonist. Dexmedetomidine is primarily used as an infusion in the critical care setting. It actually causes significant sedation. There are some descriptions of it being used intranasally, sublingually, and those definitely may be looked at in the future as treatments for this, because you definitely don't want to put every single person that comes in with xylazine withdrawal into the ICU. You can see on this slide just all the different medications that we gave her. Next slide. And more medications over a prolonged period of time. And then we did initiate her on buprenorphine. We microdosed her on. She initially was on the, as you can see, on the hydromorphone, on a significant amount. And then as we increased the buprenorphine, we were able to wean down the hydromorphine, the dilaudid. Next slide. And you can see here, this continued. She was in the hospital for approximately 3 weeks. Next slide. All right. Let's talk a little bit about the wounds. I think it is the wounds that have really captured the media's attention. And so let's talk a little bit about that. Next slide. So I'm going to start off by saying we actually don't know that much about the wounds. We do know that from the early data reported from Puerto Rico, they very early on described the severe wounds that were associated with the xylazine. We do talk to our patients quite a bit, and we ask them about it. And so you can see here, this is just a picture of what the early wounds will look like. And very often they just look like a very small ulceration with almost a bubble or just a little skin elevation above that. Next slide. And then you can see that these wounds actually progress to quite significant wounds. And I'm really sorry for, I just want to warn people, I'm going to show quite a number of slides that do show significant damage. But these are all wounds that were either seen at Cooper Hospital, at Penn, or at Temple. And again, these 3 sites, we really do share a drug environment, and a lot of our patients, are very similar. So you can see here, these are just 2 examples. Next slide. And these are more examples of just the incredible extent. Now, what's interesting is we very often mostly see them on the dorsum. We do not usually see them on the torso or on the chest, on the back, or on the face. We have seen them on the neck. And when you see them on the arms and legs, they're primarily on the dorsum. We don't see them on the palms of the hands. And they can be very extensive. Now, what's interesting is that these are not necessarily at the site of injection. And so you can inject on one side and get a wound on the other. Also, you do not need to be injecting to have these wounds. Many of the patients, in fact, use the drug intranasally or smoke it. And they as well will develop these wounds. So it does not seem to be limited to intravenous use. Next slide. And these are just some more, again, just to show you the wounds. Next slide. And these are just some more. Next slide. And this is probably one of the worst ones that we saw, where you can see the bone really just sticking out. And really, for all intents and purposes, this arm is really going to be non-functional. There's really no way to save this arm. Next slide. Now, we know that IV drug use in general has been associated with wounds across decades. We also know that very often people will have what's called a shooter's patch, and I have that just at the bottom. So it's really a wound, and especially when you no longer have vasculature to be able to inject, right? So over time, individuals, it's harder and harder to find a good vessel to inject. And so what'll happen is if you have a shooter's patch, if you have a wound, the outside border of that wound is actually very vascular. And so you can actually inject in that outer border. And so that actually has been happening for decades, but that does not seem to be what's happening here. Now, what are some of the causes? And again, we don't actually know. There's multiple groups studying this right now. Could this be partially skin picking behavior? Because there is a lot of that that leads to excoriation and then deep ulceration. The other thing is that fentanyl, people inject fentanyl a lot more frequently than they used to inject heroin. So maybe that is a component as well. As infection a component, we have cultured these wounds and many of them do not actually appear to be infected. Could this be a partial result from compression, just from pressure on this area? Xylazine does tend to cause kind of a sudden decrease in CNS status, so people just rapidly go out. But most of the wounds are on the dorsum. And so most people, even when they kind of slump over and they lean on a body part, it's not usually the body part where the wound develops. There certainly is probably a component. We know there's a component of poor wound healing. Many of these individuals are incredibly malnourished. They live on the streets. There is really not enough access to sanitary, hygienic wound care and appropriate wound care. Could there be a cytotoxin? Could it actually be the xylazine? Could the xylazine be causing something very, very specifically cytotoxic in the wound? I will also mention there is some similarity to levamisole. Levamisole was a antifungal that was in the cocaine supply and caused also these sort of eschars, necrotic eschars, largely on the ears, the nose, some of the digits. Could this be similar? Again, I think we have more questions than we have answers. Next slide. So what do we do with the wounds? One of the most important things is to try and have patients stop using a drug. That obviously is difficult, and that's part of the treatment paradigm. Keeping it clean. Now, interestingly, the debridement does not necessarily work, especially not surgical debridement. Maybe there's more potential for enzymatic debridement than surgical, covering it with antimicrobials. And then very important, when the dressings go on, they have to be non-adherent. So petroleum gauze, because what happens otherwise is they dry, and then when they get ripped off for dressing changes, it just rips off just chunks of tissue. And so you really want them to be not adherent. There is some evidence looking at the biodegradable matrices. Next slide. And then we spent some time out in Kensington with Savage Sisters and just sort of followed them around to see what they were doing. Again, everybody's sort of making it up as they go. A lot of these people are certified in wound care, but they have had to adapt. So for example, MediHoney is something that is often used with wounds. However, if you use MediHoney on a wound in an individual that does not have a home and is in the street, what you'll actually find is it'll attract a lot of flies and then maggots. And so MediHoney is used very carefully, and it's used primarily in eschars by these nurses working out in the field. You can see here there's a couple of different dressings that they use. And then some you will use Hexagen, and some will use Santal as well. Next slide. And then, I know I'm running a little bit out of time, so I'm just going to end with this, which is, are people actually seeking out xylazine? Because when I ask my patients, the vast majority will say, nope, absolutely not. Others will say yes, and if you want trank dope, you cross the bridge and you go to Kensington, and then everything is trank dope. But most of my patients are not seeking it out. And this was actually a study they did. They looked at Reddit. And they were trying to figure out, they were asking a couple questions, who they wanted to know, who's using it, how is it being used, does it impact withdrawal, and then, what were some of the complications. And actually, I apologize, it's incorrect. It said, do you seek out xylazine intentionally? That should be a 74. It's actually 74% said, no, we do not seek it out intentionally. Many of them did report withdrawal symptoms, and the use is really across the board. Some people inject, some people use intranasal. It's only about 40 to 50% of individuals said they were from the United States. So this is, the Reddit obviously is not geographically limited. Next slide. So what do we know? We know that the prevalence is increasing. We know that it may be linked to overdose deaths, although the data, there does seem to be some conflicting data. We know that it has complicated both overdose and it has complicated dependence because of withdrawal. And so we are trying to figure out the best treatment options. And we know that the wounds are a big complicating factor, especially in a population that is unhoused and has a lot of food challenges and may need a lot more support than we're able to offer. Next slide. And I just have some resources here. You can see actually at the bottom, there's a very nice PDF from Penn that they have put out addressing treatment, withdrawal, wound care, et cetera, that you can look at. And I think that's pretty much it. Happy to answer questions.
Thank you, Dr. Harroz. I think, wow, like it's so shocking to see, particularly I know with the chat, there was a lot of reaction to the slides, but we appreciate you showing us the, the true picture and what you're seeing. And so we can all be aware of it.
Yeah. Real quick, I do want to add one quick thing, which I meant to talk about, which is testing. I know people are asking about testing. Our regular drug screens do not detect xylazine. We can't. Now, when we have tested for it, we have had to send it to NMS. It's taken a week. Couple things. There are xylazine test strips out there. They're not as specific as we would like. So they do sometimes cross-react with lidocaine, they cross-react with other substances. However, they are out there. In New Jersey, my understanding is they are unfortunately still considered drug paraphernalia. So we can't actually hand them out and we can't technically use them. They do exist. Across this country, people do not routinely test for xylazine, not in emergency departments, not in hospitals. Most of that testing is actually forensic testing right now. Should we include it? Possibly. However, we would need an immunoassay to do that, meaning a quick test rather than having it to be GC mass spec, sending it out, longer testing.
All right, thanks. I'm just going to go to you with a quick question because we got a lot, Dr. Harroz, on do we see any of these reactions in animals? Because you mentioned it's a veterinary medicine, and is there any reaction to that? And then Dr. Falzone, if you want to jump in after that, if you have anything to add.
That's actually a great question. So there is some data suggesting that if you, when it's injected intramuscularly, there are some reports of necrosis in the muscle. It was mostly injected with ketamine, so it's a little bit hard to tell, but there are definitely some reports, not so much skin wounds, but more intramuscular injection.
I just wanted to confirm what Dr. Rose was saying, that testing for xylazine is not ubiquitous, even in the post-mortem world. When somebody dies of a suspected drug overdose, typically the pathologist will take specimens and submit them for testing for routine drugs of abuse. So if those tests will test for the cocaine, the opiates, the benzos, the classic groups. So if we don't ask for a comprehensive test, which is much more expensive than the routine test, those tests will actually, the xylazine will actually be missed even in the post-mortem setting. We are trying to get funding to support the counties to be able to do comprehensive drug testing, which will include xylazine and some other drugs which we may be missing completely.
All right, thanks for sharing that. And I guess another question that we have again on the wounds, about how long after initial use are you seeing the wounds? Is it after extended use?
No, that's a great question. And so the answer is we actually don't know, but what we do know is from what our patients tell us, that it's not immediate and it actually takes a while until you start developing the wounds, which also may be why we see so many wounds in Camden and Philadelphia. But if you go up to Newark, when I talk to my colleagues in Newark, they're really not seeing that much. But the presence of xylazine, we had it first, and it's been kind of spreading. So I worry that as it spreads and there's increased time of exposure, the other thing is maybe it has to do with the dose. So maybe it's just the amount of xylazine that is in the drug versus just the presence. So it doesn't seem to be immediate according to our patients.
All right. And so Dr. Falzone, you talked about methamphetamine and we talked about xylazine being in with opioids. So can you talk about, is there anything that you're seeing, things mixed with that are causing, these reactions? Specifically, people are asking, is street marijuana, is it something that we're seeing xylazine with that? Is it just with opioids and fentanyl? Can you speak to that? And then Dr. Harose, if you can add anything.
I mean, as far as xylazine, we do see a slight increase in the numbers, but nothing, I mean, usually it's when somebody tests positive for fentanyl and heroin, there's some xylazine on board. We're not seeing it, on its own. We're not seeing it with, marijuana, cannabis, and, THC and xylazine. So, and like I said in my presentation, with meth, it's usually combined with more often than not with fentanyl, mainly fentanyl, rarely with fentanyl and other analogs, which the analogs have also come and gone. Parafluorofentanyl seems to be a more one of the fentanyl analogs that has persisted somewhat, but we don't see as many analogs besides the parafluorofentanyl in the drug-related death population that we're seeing.
All right, and Dr. Rose, anything you want to add on that?
No.
Okay. I know we are coming to the end of our time. I just wanted to go to one more question for you, Dr. Rose, and then if you could just give us a final comment. Can you just comment on the effectiveness of naloxone in patients who have been using xylazine with their opioid?
Yeah. So I think what's important to remember, so number one, there is a little bit of activity at the mu receptor. So for example, for clonidine overdoses, way back when, we were always giving just a naloxone to see if it would work. But the more important part is that when patients go down, they are most likely going down from the fentanyl component. So the xylazine is synergistic and it is adding to the overdose, but the primary drug is fentanyl. So please do not give naloxone. It is very important to continue exactly what we're doing. We give naloxone and we do rescue breathing. And obviously call 911 and get them to medical care. So that does not change. That is exactly the way we've always done it.
All right, thanks. And any last thought you'd like to leave with our attendees today? Dr. Harose, yeah.
I honestly, I'm interested to see where this is going to go and what we're going to learn about xylazine, but I think it's important just to make sure that people are aware and that the information gets distributed.
All right, thanks. And Dr. Falzone, we'll leave you with the final comment from today.
Okay, I mean, like I said in the opening statement, this has been an evolving, changing crisis. Drugs come and go, and it's important to share information. We update our website with drug-related deaths on a regular basis. It's important to have collaborative efforts between law enforcement, ME's office, medical providers, and the more interaction we have, I think the better we'll be at combating the drug-related crisis.
Thank you. And I know we have thousands of people on with us today who can take the messages that we that you two shared and share them in the community and help spread the word and really get the message out. So I want to thank you, Dr. Harose and Dr. Falzone, for being with us today and sharing this really important information. And I want to thank all of our attendees for being with us today as well. We have information up on the screen on how to get any continuing education credit that you may need. And we hope that you'll join us on June 29th for our next webinar, the intersection of race, culture, and the opioid crisis. So again, I want to thank everyone for joining us today. Be well. Have a good day.